Hi everybody, my name is Nick. I'm the Pharmacy Director at the UNM Cancer Center, and I put together a presentation called Let's Put the US in USP and Get Compliant Together. I have no conflicts of interest to disclose. Our objectives are twofold. The pharmacist's objectives are to describe the background of USP, describe the importance of USP in keeping our patients and staff safe, identify common compliance pitfalls from TJC, USP, OSHA, EPA, and the Board of Pharmacy, identify tips for establishing a great USP compliance and safety process at your institution. The technician objectives are to describe the rationale behind USP and how these regulations came to be, describe the importance of following USP guidance to keep your workplace safe, discuss what technician workplace practices are important to maintain compliance, and to explain the importance of a technician perspective on USP safety and compliance committees. So my general approach to put together this presentation was to search every corner of the web and look for tidbits of information and then try to verify them. In addition, I interviewed and emailed various people locally and nationally, and I incorporated my own experiences from UNM hospitals and those experiences of some of my colleagues. As you guys know, finding information about USP and NIOSH updates can be challenging. Because what's happened in the past is there'll be a lot of hubbub about a chapter being released, and then something will come up. I think COVID probably slowed things down, and then as we know with the new USP chapters, there was some lawsuits, and then when that stuff gets all tied up, there can be a lot of delay and a lot of unpredictability about where things are going to go and the timeline for things. So on some of this stuff, my guess is as good as yours, but I tried to make it as updated as I could. And then my camera cuts off the rest of this little slide here, but any of the ideas or text you see is yours to use for your compliance. And I'm happy to share the Excels I use, my assessment of risk, and anything that you see, let me know, and I can send it to you too, and we can be a team together. Okay, some alphabet soup here. NIOSH, OSHA, USP, TJC, BOP, CDC, HHS, ONS, EPA. As pharmacy leaders, you probably already know what all these acronyms stand for. I think as pharmacists, a lot of our job is bringing together different specialties to try to get people on the same page so we're all speaking the same language. Nursing, safety, compliance, EBS, occupational health, they'll each have their different regulatory focus. Safety and compliance will be more familiar with OSHA. Your infectious disease team will be more familiar with the CDC. So part of this presentation's goal is to sort through some of this alphabet soup and come up with some ways to safely treat compounded and hazardous drugs in a way that's compliant with all of these different acronyms. So we'll start with NIOSH. NIOSH stands for the National Institute for Occupational Safety and Health. I'm sure in your hospital you're all familiar with NIOSH because they are the makers of the NIOSH list of anti-neoplastic and other hazardous drugs in healthcare settings from 2016. There was some press around a 2020 list and a little bit of press around a potential 2023 list, but as we know, those years came and passed and they did not come out with a new list. They are under the CDC, which is the Center for Disease Control and Prevention, and the CDC is under the Health and Human Services. And the Health and Human Services is a cabinet level position in the US government, so pretty much as high as you can get. So you can see here, the Health and Human Services Secretariat is up here, and then we have the CDC down here, right next to the CMS and then the FDA. So the NIOSH is part of those major governmental groups. So clicking on the CDC button, you can find NIOSH as part of the CDC centers, and it's actually on the bottom here. There's a few more centers that I cut off just so that everything fits on the slide. But usually when we think of CDC, we think of infectious diseases, but NIOSH is right here with them. Other notable divisions under the CDC are mostly infectious diseases, as you can see. So I'm going to skip these couple slides, but feel free to review them. I emailed NIOSH a few months ago, actually, and I did not get a response. They're very busy people, But if looking at this interview helps just stimulate some of your thoughts, or maybe think about some questions for your own facility, I think there is still some value there. So a few questions we have at our facility are, we're not sure when the new NIOSH list will be rolled out. It's interesting, the relationship between NIOSH and USP 800, especially NIOSH Table 5. NIOSH Table 5 of the anti-neoplastic and other hazardous drugs seems to combine all the hazardous drugs in the same precaution, whereas USP distinguishes between Table 1 and Table 2 and 3 and recommends a risk assessment. So kind of an interesting difference if you look at Table 5 and NIOSH. That's at least my interpretation. And the FDA, I wasn't sure if the FDA has an enforcement relationship with NIOSH similar to the relationship between OSHA and NIOSH. As you saw, the FDA and NIOSH are both part of the same HHS agency. And so interesting to hear more about those. So now if we look at the NIOSH website, you'll see there really haven't been too many updates over the past year or so. So what about OSHA? OSHA stands for the Occupational Health and Safety Administration. They are part of the Department of Labor. The Secretary, Julie Su, is a cabinet level position. A lot of times when we think of Department of Labor, we think of compensation and employee rights, but definitely the workers have a right to be safe, and we all want our workers to be safe and healthy, because we have a well-being component to our leadership as well as an efficiency component. When OSHA comes to the hospital, I'm sure you guys have had experience with this too, their concerns are taken very seriously. At UNMH, we'll have immediate Learning Central competencies developed, and usually they have to be completed within a week, and it's mandatory. Sometimes we'll also see signs posted due to concerns from OSHA. So when OSHA comes in, everybody takes that really seriously. And let me just highlight, they're down here. You can see right here under the Office of Secretary and Labor. USP has a grassroots background and recently celebrated their 200th birthday. I think that's kind of interesting because they're a little different than OSHA and NIOSH in that they are not directly a government level position. They were founded in 1820 by a small group of volunteer physicians concerned about quality in medicine. In 1848, Congress passed legislation and made them USP an official compendium. They didn't have a single salaried employee until 1949, so a long history of volunteers in this group. In 2009, USP introduced the Dietary Supplement Compendium to provide methodologies to help ensure the quality of dietary supplements. And federally, the FDA officially recognizes and enforces USP standards. So although they aren't a cabinet level position, or they aren't part of the different hierarchies of the government, the FDA does recognize and enforce them. Every state board of pharmacy has some language requiring compliance with USP. States are different, and we'll get into the New Mexico state regs in a little bit. In the world, there are 140 countries that recognize USP standards today. So interesting, they're not part of the US government, but they're actually recognized worldwide through this volunteer approach. There are 2 pharmacists on USP's Board of Trustees, so go us. Their documents are monographs and chapters. A pretty cool website. You can go and look up different drugs, and they'll give you quite a bit of information about them. Their monographs contain drug-specific information. However, it's much more limited than prescribing information, and it's a little more difficult to navigate. Not too useful on a day-to-day basis for pharmacists. You know, how often do you need the chemical structure of methotrexate, for example? But definitely some interesting breakdowns of the medications are in here. Now, the general rule with USP is compliance with general chapters numbered below 1,000 is required when referenced in another general chapter below 1,000 in monographs or in general notices. General chapters numbered 1,000 through 1,999 are informational. It's a funny approach, and I'm not sure really their philosophy about that, but that is why USP 800 wasn't official till 797 was official, because it had to have this cross-reference within the chapters below 1,000. So it was kind of an interesting rollout because USP 800 looked official, and there was really no changes with the USP 797 lawsuits, but USP 800 wasn't technically official until 797 had to work through all their, work out all the kinks. So again, I did try to reach out to USP about some questions, and I did find the answers to some of these. But I'll skip over this section since USP did not get back to me. Despite I did interview or try to interview him a couple months ago, but I understand they're busy people. There are some things that I should point out though that I was able to look up and find myself. In section 4 of USP, it suggests that the designated person should be one person, and it can be a team. So the designated person is one or more individuals assigned to the facility to be responsible and accountable for the performance and operation of the facility and personnel for the preparation of compounded preparations. Facilities must determine whether they have one or more designated persons, select the designated persons, and determine how to allocate responsibility if there's more than one. The designated persons can delegate activities to an assigned trainer provided that that's described in organization policies. So yes, the designated person can be a team. Don't put this all on your shoulders, especially if you have a big organization. And make sure though it's listed in your policies so that when TJC comes or the Board of Pharmacy comes, you can point to it. One other question that I've kind of had is N95 masks. The USP 800 kind of glosses over them. It doesn't really mention a specific place for them. They do mention that surgical masks don't provide respiratory protection, but an N95 doesn't protect against vapors and does little to protect against splashes. So kind of interesting when you're working in a BSC if N95 would add any value. I think a lot of the institutions locally that I've spoken to don't use N95s because they're pretty uncomfortable and they don't seem to offer much more protection for our workers. So I also kind of asked USP if Chapter 800 conflicts with Table 5 of the NIOSH list, just circled it here. Again, Table 5 in the NIOSH list, it seems like there's not a lot of attention paid to that specific table, and a lot of the focus is on the drug tables 1, 2, and 3. So now getting into the Joint Commission, TJC. I have a little bit of experience with the TJC. I've been a pharmacy director for 2 TJC visits, and we're getting ready for our 3rd coming up in the summer. I have a few slides from a TJC presentation given February 16th, 2024. The TJC is going to want to do a pop quiz, so be ready. Sometimes TJC sits down with your compounding techs or pharmacists and goes through procedures, but in my experience, they've wanted just to ask some questions on the spot. They may ask to speak to one of your techs and have them walk through all the steps. So in this slide here, make sure your techs are sharp on their hand hygiene, garbing, cleaning and disinfecting, and all of this stuff, and they can demonstrate it on a whim. The tough thing about TJC is they are an authority figure, and they can make us all very nervous, especially because we're being quizzed and held responsible for what we say. And again, it might not be a sit-down thing, so make sure your techs are ready to speak to all of these things here and all their procedures on the spot. So one big change to the USP Chapter 797-2008 and then the 2022 USP Chapter are the surface sampling. So surface sampling used to be periodically, and we do it along with our variable air sampling. But as you can see here in the updated USP 797 chapters, it's required to do surface sampling monthly for Category 1 and 2, and that's where most of us are. One thing that USP doesn't really talk about is what to do if you fail a test. According to TJC, this presentation here, they said revised chapter does not require retesting for highly pathogenic organisms, but it does require trending and an action plan based on organizational policy. So make sure you have in your policy what you're going to do when you fail a test, and make sure you have a nice organized folder for any failures and all the testing you're doing, just to show them on how you're responding to the test. I would think that if you're failing multiple tests and you don't have kind of an extensive plan, they're probably going to raise some concerns. But the good news is, if you fail a test, you don't have to shut down your IV rooms until you can retest. So TJC's perspective on USP 800. I'll start with this slide, the bottom slide here. So watch the must and shall. That's definitely something that they're gonna test too. So if there's musts and shalls in the USP 800, you're definitely on the hook. Now, they say that administration is out of the scope. So example, administration is out of the scope for USP 797 and therefore will not be required for 800 concepts. But I know in our facility, they want to see a nurse give a hazardous drug. And so I don't think I'd count on that. I think you should definitely make sure your nurses are ready to give chemotherapies according to policy. And definitely make sure you have good policies in place and your nurses are well trained to give hazardous drugs. So TJC has a 3-year rule with training and competency. They're not specific on what kind of training restocking staff, in-process checkers, final verification personnel, like pharmacists, immediate use compounders. They're not specific on the training that must occur, but they are specific that training must occur every 3 years. So make sure you have a nice place to make sure your training is documented. At UNMH, we have a system called Learning Central, where we have annual competencies, and they're kept in a nice organized format that's easy to pull up. So the idea with TJC is that staff competence is assessed and documented once every 3 years. So make sure you can speak to your training, and again, make sure you have a nice organized place to pull it up when needed. One website that we won't get into too much, but I just wanted to mention them because they are a resource that sometimes the New Mexico Board of Pharmacy uses, is Critical Point. In 2020, Critical Point and Eric Castongo were was acquired by TRC Healthcare. And basically what Critical Point is, is their consulting group that specializes in USP compliance. So you can see here we have sterile compounding, hazardous drugs, and non-sterile compounding. So pretty in line with the USP chapters. But they also do other pharmacy educational topics. There are a bunch of resources on their websites, and they have CE, but again, it's a paid service, so not one of the free services. One other resource I wanted to mention is a free one. I'm sure a lot of you pharmacy leaders already have your free subscription to Pharmacy Purchasing and Products. Pharmacy Purchasing Products has just the right amount of heads up. When you flip through their magazines, you might have some aha or oh, I didn't think about that kind of moments that then you can go share with your group. So just kind of a lot of keeping up with the Joneses kind of thing. The magazine is full of ads, but there are some great surveys and quick articles to help you keep up. They have articles on EPA regulation, which we'll get into, USP 795, 797, and 800. And there are also surveys on other facilities' approaches to compliance. You can see I circled one here, which is prepare for state board a clean room inspection. So some helpful, just practical stuff in there. The articles are really easy to understand, and they're written by pharmacists that offer different perspectives. There's a lot of great information for text there. Every once in a while, they'll have some free CEs. I've done a few live webinars, which are really high quality through this group. So pretty interesting, free resource, but again, you have to sift through a lot of ads to get the information out of it. So let's get into ASHP's compounding resources. These are free if you are a member, and they made some wonderful resources for comparisons between the new and old USP 797 and 795 chapters, and a good heads up for 800. The 797 and 795 chapters or reviews from ASHP are largely the basis for the New Mexico Board of Pharmacy regulation updates. So definitely good to know. and these updates are comprehensive, and we'll go through them. There are SOP guides as well in the ASHP compounding resources. So when putting together your guidelines, make sure to double check them against the ASHP resources. Again, the board, New Mexico board, will be looking for these. This is just insider tip. This is how they went through and updated their regulations. They also have new publications of their answer books. So their answer books, I think they cost like $100 each, but they're super helpful Q&A books that have frequently asked questions about the different chapters. They're written by Patricia Kinley, who's just kind of a guru on these chapters. So full of clarifications and hundreds of answers about frequently asked questions in there. So what's the talk at ASHP? As I mentioned, ASHP put together a few supplements for 797 and 795, comparing the 2008 and 2023 versions. You can see here in the salmon, or in the white column, you have the different points from USP, and then in the salmon color here are the 2008 text, and then the 2023 here is in green with the updated text. So it goes line by line and compares any changes between the two chapters. So it's just a great resource if you're already up to date with USP 787 from 2008 to get you up to date for 2023. The Board of Pharmacy spent a lot of time looking at this to update their sterile compounding chapters, and I'm sure they'll be updating their 795 chapters with a similar document, although of course there aren't as many updates from 795. But if you want to be ready for your next Board of Pharmacy inspection, spend some time looking at this document. One thing that surprised me is that you don't need persistent killing anymore, but you still need alcohol-based hand rub after washing, but prior to donning gloves. So just a little tip, just to show you how much detail they go through in this document. So I made my own table going through the chapters using these ASHP documents. So again, those ASHP documents are free to members, and I think if you Google them, you can probably find them too. But let's go through some of the key points and some of the things that I think are interesting. And again, you can feel free to email me if you want this document, and definitely email me if you find any mistakes or any updates. But let's walk through it together. Okay, so bear with me because this is my crazy way of organizing things. Basically, when I get a little kernel of information that I think is useful, I put it in different shared documents and then share them with people. This document is my document called Hood Talk, and it contains most of the stuff, little kernels of knowledge I've collected regarding hoods and clean rooms and cleaning and things like that. Again, I'm totally happy to share this with you. Just let me know if you want a copy, or if you find any mistakes, please let me know. So what I did with this sheet was I divided the columns into 795, 797, I'm sorry, 795 is over here, 795 and 800, and then just a little note section. And then I went through all three of the chapters and just looked for differences or different talking points of each of these potential topics. For USP 797, I divided them into category 1, category 2, and category 3. And then immediate use. For 795 and 800, they don't have the different categories, so that's why you'll just see the two columns. For BUDs, this is where there's a lot of differentiation between category 1, category 2, and category 3 drugs. For immediate use, the BUD is used within 4 hours from the start of preparation. Category 1 drugs only have 12 hours at room temperature, whereas category 2 has 4 days at room temperature if using sterile ingredients. The 795 doesn't get as detailed on the specific location of where you store it, and of course there's no categories in 795. But note that oral liquids are good for 90 days, whether you're refrigerated it or not. So refrigeration doesn't give you more days with oral compounds. Non-preserved aqueous dosage forms must be refrigerated, and that's how you get your 14 days there. There is additional information with sterility and terminal sterilized things that I put here, but it's kind of outside of the scope of this talk. And then freezers. Freezers give you a little more time. Sterile or non-sterile ingredients, you get 45 days. If there's no sterility pass, you get a little longer if sterility is passed. There's no information from 795 or 800 about freezers. For 797, whether it's in a category 1, 2, or 3, it must be compounded in an ISO 5 PEC. For 795, there's really no information on hoods, but 800 talks about the class 2 or 3 BSCs. And then you need to use your plastic back mat and change it frequently. They do mention in 797 the proprietary bag and vial system. For immediate use, you do not need a hood, but if you're going to prepare the proprietary bag and vial systems for future use, you do need to make them in a hood. There is a little differentiation in the room. For category 1 preparations, if your PEC or your RABS is in an SCA, that's okay. But for category 2 and 3 preparations, they must be in a clean room suite. The PEC or RABS must be in an ISO class 7 or better buffer room with an ISO 8 or better anteroom. Remember, there is a difference here. For USB 800 compounding, the anteroom must be a class 7. So that is a little bit of a difference between 797 and the hazardous compounding in 800. Isolators don't need anterooms, which is kind of an interesting point in 797. The ingredients, if you're making immediate use, you can only use sterile components, whereas for categories 1, 2, and 3, that's where you can have sterile or non-sterile components. Initial competency, for immediate use, it didn't give any information, but again, for TJC, there has to be competency demonstrated at least every 3 years. Garbing competency, including fingertip test, no fewer than 3 separate times in succession, which can make you kind of nervous. You got to get it in a row. And then there must be initial HD compounding per the SOP in USP 800. The frequency of compounding competency is every 6 months for categories 1 and 2, and then every 3 months for categories category 3. For USB 795, the competency must be demonstrated every 12 months, and HD training must be every 12 months. Competency frequency for those with direct oversight but don't compound, that's every 12 months in all 3 categories, and 12 months for 795, and there's nothing about specific competency for in USP 800 in terms of frequency, but it does say all personnel who handle HD must be trained. Frequency for those who only check CSPs or only clean the sterile room environment is per SOP. Again, per TJC, it must be every 3 years. Hopefully more frequent than that. USB 795 says the same thing per SOPs. And for 800, it only specifies those who handle hazardous drugs. Again, I would think yearly is best, but at least every 3 years. Where to don garb? For category 1, if not in the classified area, must use alcohol hand rub prior to donning. But generally, you want to don your garb in the classified area. There's a line of demarcation in the HAZ room for donning and doffing. So remember, when you're going into your HAZ room, you need to put on your second pair of booties as you cross over that line of demarcation. So that's an update for USP 800, that you have to have a second line of demarcation in your hazardous room. Reusing gowns. So for categories 1 and 2, if it's on the same shift by the same person and the gown is maintained in a classified area in a manner that prevents contamination, you can reuse gowns. With category 3, there are no reusing gowns, and gowns have additional expectations. For instance, no skin can be showing, the garb must be sterile, and there must be SOPs for disinfecting goggles, etc. And then, of course, in USP 800, you cannot reuse gowns. They must be disposable. And you should change gowns every 2 to 3 hours, and you should change chemo gloves every 30 minutes or more often per the manufacturer. Dynamic airflow frequency or laminar flow checks should be every 6 months, regardless of your category for USP 797, and there's no information on 795 or 800 about that. PEC certification should be done every 6 months or every 12 months if in USP 795. Interesting difference there. Viable air sampling, no real changes. Should be every 6 months for USPs for categories 1 and 2, monthly for category 3. Surface sampling, so that's our big update. So that should be monthly for categories 1 and 2, at least weekly and more frequently depending on batches and BUDs for category 3. See see USP 797 for more information on that. Chemo surface testing should be every 6 months. We do it here at UNMH every 6 months. But again, that's a should in the USP 800 chapter. So cleaning and disinfecting the PECs, the pass-throughs and floors should be cleaned daily, regardless of what CSP category you use. In 795, the work surface should be cleaned daily when compounding and between different components. Other surfaces should be daily. Deactivation and decontamination should be daily and after a spill in USP 800. Cleaning, disinfecting the walls, ceilings, storage, shelves, equipment outside the PEC should be monthly in USP 797 categories 1 and 2, weekly for category 3, every 3 months for USP 795, and then under the work surface of a hood, monthly. A PAPR or respirator is a should. The cleaning agents must be sterile, so that's an update from the old USP 797. I know for us that added an extra cost. You know, you have to buy these, the sterile alcohol and the sterile cleaning agents, they're zapped with some like radiation or something like that. It's kind of funny to think that cleaning agents might not be sterile, but they actually have to be sterile cleaning agents now. Sporicidal disinfectants must be done monthly for categories 1 and 2, and then weekly for category 3. No information on 795 or 800 on that. Sterile 70% IPA. After cleaning the entire PEC to remove residue, so especially if you're going to use compounds that have bleach or could potentially be oxidizing, you want to wipe them down with sterile IPA so that you remove the residue and remove potentially the oxidizing components of the bleach. To horizontal PEC, so again, your work surface every 30 minutes as long as it does not interrupt a compounding procedure. So definitely be wiping down those hoods frequently. Compounding records. So there should be a compounding record for immediate use if the person who makes the immediate use is different than the person administering it. So there should be a compounding record in that case. For categories 1 through 3, there should be a compounding record for every single CSP. For USP 795, you must have a record for each CNSP. 800 does not have any mention of the compounding records. Sterility testing. No sterility testing is required for CSP category 1, but category 2 requires sterility testing if the BUD requires it. Category 3, of course, requires sterility testing. No information on that for 795 or 800. Bacterial endotoxin testing, so not for category 1, but if you're going to use non-sterile ingredients, that's when you have to do your bacterial endotoxin testing, even if it's category 2. Labeling, you do need to label an immediate use compound if the person who is preparing it is different than the person who is actually giving it. So the labeling for USP 797 categories 1 through 3 is similar. It should indicate that it was compounded, which is something we had to cram onto our label. Even though it seems pretty obvious, it's just something that they want you to do now. It is required to have labeling in 795, but interestingly, they don't put the compounded label requirement in 795, even though it seems like it's a lot of times it's less clear that it was compounded rather than bought from the manufacturer. If you're making it like an oral syringe or something like that. And then in USP 800, the label must include that it's hazardous. Multiple dose CSPs. Multiple dose CSPs are not allowed for category 1s, but they are allowed for categories 2 and 3. And then multiple dose ophthalmic or topical CSP with no preservative, not allowed for category 1. It is allowed in category 2 and 3, 24 hours at room temp or 72 hours refrigerated. So hopefully that table helps break down the differences between the 3 categories. And then just highlight some of the things to think about for USP 795 and 800. So we'll take a break real quick for a TJC trap. The TJC and the Board of Pharmacy are intimidating. They don't mean to be. The Board of Pharmacy is wonderful to work with, but you get nervous. They're authority figures. I definitely get stage fright with dealing with them, especially TJC, because they only come every 3 years, and it's a big hospital event. But remember that TJC and the Board of Pharmacy, they're expected to follow all the same rules as everybody else. And in fact, they want you to tell them the rules that everybody has to follow to make sure that you're conducting business in a safe and effective way. So what we did is we have this checklist here that is laminated and put on our doors. And it requires that our techs go through this checklist verbally with anybody who wants to enter our IV room door or IV rooms, kind of like a cheat sheet, because there's a lot to worry about. You know, if somebody has makeup on or excessive jewelry or they're carrying a bag or something like that, those all should be left outside of the room before they come in. And you know, this is going to win you points with TJC and the Board of Pharmacy, that your techs are so thorough that they're questioning everything about the person before they let them in, you know, your clean room suite. So the regs do require that any person entering a clean room, a sterile compounding area, whether preparing a CSP or not, must meet the requirements in 3 personal hygiene and garbing. And that language is more specific than it used to be. So make sure we're not just letting anybody in our clean rooms, even to look around or check it out, unless they are ready to go in terms of cleaning and in terms of the hair and the makeup and all that stuff. And feel free to let me know if you need a copy or you have any suggestions or concerns about it, and we'll get this updated together. So here's a zoomed in version of our mandatory visitor information to enter our cleanroom suites. And I thought I'd just go over some of the points with you. There's no cell phones required past the line of demarcation, and you know, nowadays everybody carries a cell phone, so it's important just to ask, you know, when people are coming in. I do sometimes have trouble telling if somebody is wearing makeup, and so again, it's just part of our policy to ask people. You don't have to feel rude about that. And then hand and wrist jewelry, you know, sometimes people's sleeves are down, and so you can't see if they're wearing jewelry, but definitely that's not allowed. And then artificial nails. Again, these questions are just part of our procedure. It's nothing rude. It's just what we have to do to have people access our clean rooms. This also helps, you know, remind us of the 30-second rule for washing hands. I kind of joke that if you're only washing your hands for 30 seconds before going to the clean room, you're probably not doing it right, because usually it takes longer than 30 seconds to make sure you're washed all the way up to the elbows. And then it has information about how to glove and gown. Just again, a quick cheat sheet to educate people that are coming into your clean rooms. But this isn't only for the Board of Pharmacy and for TJC. This also helps when a facilities person wants to come in and may be confused about you know, some of our how strict it is to enter these rooms. You know, not everybody has the experience of entering a clean room, and so it helps to give your staff something to stand by and say, hey, I'm not being picky, I'm not being difficult with you. This is just our procedure, and so I need to go through this with you. So I wanted to delve into temperature and humidity, there's an update in the 2023 version of the USP 797. In that temperature and humidity monitoring devices must be verified for accuracy at least every 12 months or required by the manufacturer. This doesn't necessarily mean that they need to be certified, but that does seem like the most straightforward way. I've heard one facility using a manual temperature, you know, or like an old school mercury thermometer, and comparing it to their electronic thermometers every year, and then writing down the discrepancy. But that seems a very cumbersome way to make sure your electronic thermometers are updated. And I don't know that that's going to stand up to the rigors of the boards of pharmacy and TJC. So I think it's probably best to get actual certified thermometers. Many probe certifications have a 2-year shelf life. The big names, you know, Primex, Sonic-U, Traceable, Centrac, they all have probes that have their certification, and they have probe replacement plans every 2 years. There's also data loggers that are cheaper and certified, and they might serve as good backups. A lot of times with Primex, Sonic-U, and Traceable, you're paying for the internet subscription. So when the thermometers go out of range, they send an alarm, and then there's a constant recording on their website and things like that. So really it's the web services a lot of times that you're paying for. So the data loggers, you don't pay for the web service, but you don't get the alarms, but they do keep track of your temperatures. I like the data loggers as backups, especially if you're dealing with study meds, because say your internet goes down or for some reason one of these thermometers loses power, you'll still have the data loggers that are going to keep downloadable data while your main system goes down. Interestingly, humidity is in Chapter 797, but not mentioned in 795. But I do think we should generally be keeping humidity. I know in New Mexico there's about 2 days of the month where the humidity is more than 60%, if that, in the summer. But it's definitely something we need to keep an eye on. At UNMH Pharmacies, we're transitioning to SoniQ. So far, I've liked it. It's got a good web service, and the thermometers guy came out and installed all the thermometers, and is a great process. If you're designing a clean room suite, request that the temperature control to the clean room be separate from the rest of the building. At the Cancer Center, they are actually the same. The HVAC system temperature control is the same as our infusion suites. And so, we have patients with cancer that might get a little colder, whereas our techs are garbed up and on their feet all day, and they can get a little hotter. So, so definitely just a pro tip, when you're designing clean room suites, try to make sure you have your own temperature control, because the temperature should be kept a little bit cooler in your clean rooms than the rest of the facility. So for monthly surface sampling, we talked about how now in USP 797, for category 1 and 2 compounding, you have to do surface sampling at least monthly. In our experience, it's been one of the most significant changes to USP 797, that we must now have this every month. But again, the question in the chapter is, what do you do if you fail it? And they don't give much guidance. And as we saw, the TJC isn't going to ask that you shut down your IV rooms. But I would take it very seriously. Again, if you find trend and sample after sample, that just isn't a good look. And I think that would raise some eyebrows for the Board of Pharmacy and for TJC. So far, documentation and remediation. And make sure these documents are well in order, because the board and TJC will definitely ask you about them. And describe corrective action, and make sure to have your clean retest neatly attached to demonstrate remediation. Again, the retest could be a month later, and hopefully it's clean as a whistle, and you can just show them that you made your changes and you cleaned things, and now look, it worked, and you don't have this issue anymore. So some other key changes and important points. One point I always like to make, this is not an update from the old USP 797, but compounding per approved labeling is not in the scope of the USP 797 chapter. So compounding does not include mixing, reconstituting, or other such acts that are performed in accordance with directions contained in approved labeling or supplemental materials provided by the product's manufacturer. So if you're compounding per the manufacturer, that is not in the scope of USP 797. There are some updates to incubation times and criteria. Definitely you should go through. Those can be a little more onerous because you have your different temperatures. And then now that we're testing every 6 months instead of every year, those incubators can be a lot busier than they used to be. No hand dryers at the University of New Mexico Cancer Center. We had hand dryers, and we got rid of those. The CAI and CACI must be placed in an ISO Class 7 buffer room. Hopefully you already did your remodeling by now, because that would be a big remodel for a lot of people, I think. There's more specific information on handling viable air and surface sampling. Data collected in response to corrective actions must be reviewed to confirm that the actions taken have been effective. The corrective action plan must be dependent on the CFU count and the microorganism recovered. So just make sure you're including just a detailed response on your corrective actions. There's updated release inspections and testing, and then there's more detailed notification of recall information. So now I wanted to share with you an interview I did with Christina and Helga. They are our UNM Hospital's IV room experts, and they are definitely specialists in their field. And they're definitely two of my favorite people at the University of New Mexico Hospital. They didn't want to be on camera, so it's just me smiling and being goofy, but the sound quality came out pretty good. It is a little choppy in a few parts because I edited a little bit of the ums and stuff out, but I think it turned out pretty good.
Hi, hello everybody. My name is Christina Kim. I'm a pharmacist at the University of New Mexico Hospitals, and I am a supervisor in inpatient supervising the operating rooms, pharmaceutical services to the operating rooms, as well as procedural areas such as the cath lab, interventional radiology, GI, and I also manage the pre-anesthesia clinic pharmacy and run the sterile compounding facilities with my colleague Helga Hansen.
Hi, I'm Helga Hansen. I'm a tech supervisor, working really closely with Christina, um, staffing in the IV room, but also taking care of all the testing, dealing with ProTech and anything that involves the IV room training, et cetera, et cetera.
Okay, great. So do you guys have a designated person full-time, or is it part of an existing role? Is it a tech or pharmacist, and does the designated person have a job description?
So the designated person can be a little bit of a confusing issue. The Board of Pharmacy requires a pharmacy to have a license, and that license has to have a pharmacist in charge that knows the daily operations of the pharmacy. And so in general, that PIC knows the daily operations of the pharmacy, including sterile compounding. So we consider that person to be the PIC and to be the designated person for sterile compounding. However, you can have designees from that role. So for example, I'm a designee for the sterile compounding areas at UNMH, and I would consider Nick to be the pharmacist in charge for CRTC, and that has its own separate license. And so as a result, he would be the PIC for CRTC, and he would have a designee that would run the daily operations of the sterile compounding areas, hazardous and non-hazardous, and be trained and be competent in all those practices. What do you
Great.
think, Nick? That's
Yeah, no, that sounds
okay.
great. That's I am the pharmacist in charge over here. And yeah, it's a big role. It's a big role to take on. Are there any new precautions you're taking to TJC proof your facility?
Yes, so we have completed a gap analysis with our sterile compounding oversight team using the ASHP USP 797 key changes document to make sure we've checked all the boxes and we know what the changes are. And in addition to that, we've crosswalk regulations with our current setup. So looking at all the changes to make sure that we are compliant with the current setup versus the regulations, and also working with our medication safety officer to educate the staff on these changes so that they can appropriately respond to questions that are presented to them by the Joint Commission, and also so that they themselves know what the changes are and can provide direct oversight for the compounders.
Okay, great. Can you talk a little bit more about your sterile or your Sandspot team, the sterile prep team?
So here at UNMH, we have a committee that is referred to as SANSPOT, and that stands for the Sterile and Non-Sterile Preparation Oversight Team. And that is an oversight committee that we meet every 2 weeks, and we discuss lots of different issues. We discuss new 503B companies that we're trying to vet in order to purchase 503B products. We discuss stability issues, sterility issues. We discuss recent certification, monthly sampling, all the issues involving sterile and non-sterile compounding we bring to this committee. So if there's questions, if we need to vote on procedures that we are presenting that we would like to utilize in our different departments, we bring all that information to this committee. And decisions are made by a team of people who have knowledge about sterile and non-sterile compounding.
Okay, great. What CSTD do you use, and how's your experience with it?
Should I take that?
Yeah.
So currently we're using EquiShield since, around 2 years. Um, what else do you want to know? Like what our experience is with it? I like it because it's a closed system, so we're never exposed to the hazardous toxic drugs. So it's quite expensive, so we're trying to be manage it nicely. But overall, I think we're pretty satisfied with it.
Okay, sounds good. What's your process for clean room daily cleaning?
Okay, so we when every shift comes in, the beginning of the shift, we do the kind of like a deep cleaning. So we clean with Virex, sterile alcohol, and or sterile water if needed. During the day, throughout the compounding, every day, we constantly clean with sterile alcohol, which we keep in the hoods, and Virex if needed. Um, like I said, every shift in the beginning does a more thorough cleaning, but we basically clean all day long.
Do you clean 3 times a day then? 3 shifts?
Yes, yes.
Okay.
In the beginning of the shift, we do kind of more like a deep cleaning to start your shift, but constantly throughout the day, we clean, we wipe everything that goes into hood, we clean the ante room, clean the containers, we carry stuff with alcohol. So we basically clean all day long in
Okay.
a roundabout way.
Sure.
May I add something to all that?
Yeah.
Of course.
I would also like to add that we do follow 797, the table
Mhm.
10, the minimum frequency for cleaning and disinfecting surfaces. And so anything that we might not have mentioned about our cleaning practices, anyone can refer to that particular chart in the new USP 797 regulation. And that's what we follow.
Okay.
Thank you, Christina.
Do you use a continuous pressure monitoring system?
Currently, we're physically checking the pressures every shift.
Every shift. Okay, 3
Yeah.
times a day.
Mhm.
Great.
We would like it to be continuous, and we're working towards that, correct, Nick?
Yeah, no,
Yeah.
with
The
with Sonic-U,
with
hopefully
Sonic U,
hopefully
yeah,
soon. Yeah.
it's gonna be
Um,
continuous then, right?
yeah, well, hopefully not too many alarms. We'll see. I hear there's a what do you call it? There's a like a grace period when they open the door, so it doesn't just alarm every time somebody opens the door.
Oh, thank God, right?
Yeah. What is the biggest hurdle to implementation of the USP changes?
I think in general, we were already prepared. We did have systems in place. I think rewriting and the standard operating procedures, just carving out time to get that done, even though we do follow them. But in terms of converting everything, I think sometimes space can be an issue, like for example, in the segregated compounding areas, being able to carve out a 3-foot or a 1-meter line around around the glove boxes that we utilize in those areas, and support from the hospital to make those changes is is there, but it can be a lengthy process to go through. I think Helga, you probably have some hurdles in terms of testing.
Yeah, I can talk to that if you want. So
Yeah, I mean, it's a
yeah,
big change.
yeah, it's a little bit more complicated. I actually have to fingertip or relevant personnel twice a year now, which is quite a big number, as you can imagine. Also, the incubator, I'm just trying to read this here, they're a little bit more for the initial testing. The incubators are a little bit harder to manage, like the plates and the broth have to stay in 2 different temperatures for more days now. So I have a lot of red dots everywhere telling me where I'm at in my days. We manage, but that's a big change. And then also the initial testing is done a little different than more gowning and washing than we did before. So yeah, I think we're gotten used to it, but definitely some changes.
Okay, great. Are there any welcome changes from the new USP guidance?
Yes, actually, we did get a bit of a break on storage dating. I mean, for example, in the past, we had low, medium, and high risk,
Mhm.
and now we have category 1, 2, and 3. Under the old regulation, our storage time was less, room temperature and refrigeration dating. And so now, for example, with room temperature, we get 4 days worth of dating and 10 days in the fridge. Whereas in the past, we were basically working with 24 to 30 hours and 9 days in the fridge.
I think you also mentioned, let's see, oh, you liked the surface sampling, the more
I
regular
did.
surface sampling.
Yeah,
Yes.
so
Mhm.
another welcome change from the new guidelines are the requirement for surface sampling regularly. It provides more feedback for compounders and provides feedback for us to, in general, trend and know that we are staying clean.
Yeah, I like it too. And I think we're doing pretty good with it. It just gives us more of a checkup.
Yeah.
What's your approach to non-sterile to sterile compounding, and how does this compare to what we've done in the past?
Well, currently we do not have a non-sterile to sterile compounding program. We did in the past, but the requirements are more stringent, and we don't have demand for this process. So we are electing not to non-sterile to sterile compound at this time.
Yeah, no, I'm not too excited about myself.
Yeah.
Are there any circumstances where you would require staff to use N95 masks for hazardous drug handling? It's mentioned briefly in the chapter, but I couldn't really figure out how it really fits into our day.
Was it in 800
It's in
or?
800 and it just briefly speaks to them. It says N95s, they can protect from dust or what is it, particles, but not vapors. Um,
Right.
and so it just seems like I think they're uncomfortable, and I just in our side we don't wear N95s while we're doing hazardous drug compounding.
So, yeah, so to a question like that, I would respond by saying we do not require staff to use N95 masks for hazardous drug handling. They are they are available if the staff member would like to wear them. They're not required, but when we're working in the BSC, we have a glass um, lever, if you will, in front of us that protects us from splashes or from contact um, with the product itself, in addition to using the closed system transfer device.
Right,
Yeah.
the sash, yeah. The
The sash,
and
thank you.
in our spill video, we actually have the nurses are using N95s to clean up spills, and I guess that makes a little more sense if you're worried about particle generation.
Right, especially when you're, if the spill is on the floor or,
Right,
in a place where you're not protected,
yeah,
with a sash, for example.
Yeah.
right. What do you use to clean under the work surface of a hood, especially a BSC?
I usually just wear my regular, my mask and whatever regular wear. We have a capper available.
Mhm.
So we used to have technicians who choose to put that on when they clean,
Okay.
like when you do the weekly cleaning and you take it all apart. So
Right, it's mentioned in USP 800. It's not a must though, but it is a higher risk when you're cleaning under
Right,
there, of course,
right,
than
yeah.
right.
just because
And
stuff
so
can build up.
that's, yeah. And so therefore, that's why we purchased it and have it available.
Yeah, great. And then our last question: how do you assess outsourced vendors? Have you found any outsourced vendors who use the new ASHP outsourcing vendor dashboard?
I think you have to answer that
I know.
question, Nick.
I know. I think I might just talk to this myself, but I was just, it was just to, maybe just to remind myself how to do it. But honestly, I have not found anybody who uses that dashboard. And, we work with the big boys, Nephron and stuff. And I
Right.
can't find anybody who uses that dashboard, but I can get them to fill out the form. you know, the ASHP self-assessment form. But as for the dashboard, I think people, I don't know, I guess the word just never got out.
Yeah, and as the Sandspot committee chair, I could also add that we have an assessment tool that we use that was created by Nick, and that assessment tool is used to evaluate, and then the evaluation is brought to Sandspot for an initial approval, and then reviewed once a year after that.
Perfect. Yeah. Okay, cool. Well, that's all I had. Is there anything else you guys wanted to speak to?
Not that I can think of.
Thanks,
That's it.
Nick.
Thanks, guys.
Thank you.
Cool.
Okay, bye.
Thanks. ASHP has a similar key changes document for USP 795 that they do for 797. The good news is there isn't as many changes as there were for the USP 797, and the chapter USP 795 just isn't as long. So this is a pretty quick read. I would read through it though, because again, the Board of Pharmacy does review this stuff and look for changes, and definitely when they come to your pharmacy, they're going to want to make sure that you're following all the updated practices in these documents. One thing to note is you still need a designated person for USP 795, and competency and training must be documented every 12 months. So definitely understand the requirements of 795, understand and interpret safety data sheets and certificates of analysis if applicable, and then just read and understand procedures related to compounding duties, and make sure you're making your own procedures at your facility. Overall, the changes to 795 were not quite as significant as 797, and again, part of it is just because the chapter is shorter. But hopefully a lot of it is no-brainer stuff. Some things I highlighted here: no oozing wounds. It's just tough to even read. Make sure to wash your hands, wear gloves, have your SOPs put in place. Measure temperature at least daily. And again, they don't mention humidity, but it seems like a best practice. And I know certain groups like URAC require humidity monitoring. And definitely if you're doing studies, they'll probably require humidity monitoring as well. Visual inspection, appropriateness, defects, and leakage. Definitely when you do a visual inspection in 795, sometimes you'll have floating shells of capsules and things like that, which might be perfectly normal, but just make sure it looks normal. And you still need a designated person. But again, it can be a team of people or a single person. Okay, so I did an interview with the Board of Pharmacy. I interviewed Chris about his thoughts on updating the regs. He didn't want to be recorded or on camera, so I promised not to record it, but we did agree that I would share the notes from our interview. It's funny he didn't want to be recorded because he's so sharp and he's so on the ball. And so, it was a great conversation. It's always good to talk with Chris. The way we updated the Board of Pharmacy regs were we had 4 pharmacy members from the community meet with Chris about 3 to 4 times to go through the Board of Pharmacy regs and compare them to the ASHP's USP 797 update sheet that I've already shown you guys. And this was the Board of Pharmacy, of course, driving the show, not me. I just interviewed Chris. So here's my Board of Pharmacy interview. My first question was, what was your process on updating the regulations 16.19.36 for USP 797? Chris answers, we crosswalked the ASHP key changes document, which outlined USP 797 from 2008 and compared it to 2023 and broke it down into various categories. At the same time, we went through regulations and crosswalked relevant differences. We looked for places where there was a particular area that was in regulation and also on the form and needed to be updated. We clarified, updated, and added language for definitions to align with the new USP 797. And to speak from my experience, we went through all the definitions and all the regs and just made sure everything was updated and needed, and added a few things. There weren't a ton of changes. Were there any other regulations affected? No, we only changed Chapter 13 in regard to the new 797. USP 800 just became official. We made 1 or 2 minor changes as a result of 800, but again, nothing big. And this will all be presented in the new Board of Pharmacy regs. Will there be a similar process for updating the regulations 16.19.30 for USP 795? At the time, Chris was not sure yet. I sent him over the ASHP 795 document, in case they wanted to start another group for that. So next I asked, pharmacies will be responsible for following the Board of Pharmacy regulations in addition to the USP documents, correct? Yes, that's correct. No specific verbiage, but if you look at Chapter 36, it basically states in the objectives of that regulation that it's to establish standards that are in accordance with Chapter 797. 797 is referred to multiple times in 36. The goal is not to restate what's in 797 or any chapter. The goal is to be a quick guide in addition to 797, not a whole lot that's different from 797. And remember, the designated person is responsible for training, and the designated person by regulation is the PIC, the pharmacist in charge. So that's an interesting point. Be prepared for that when the Board of Pharmacy comes. Know who your designated person is and know who your PIC is. And if you are the PIC, be ready for having responsibility as a designated person, even if you share that responsibility with a team or another person. Is there any low-hanging fruit that we can make sure our staff is educated on? Garbing and gowning is usually done well, cleaning is done well, but sometimes there's a disconnect between those in the clean room and management. There are things that the compounders may be aware of and they aren't making the management aware of. Loose ceiling tiles, for example, exposed or damaged paint, cracks in the flooring, facility issues that compounding personnel see and don't report. For our example, I know that one time there was a chip in the sash on one of our BSCs for a while, and I think our technicians assumed that our pharmacists were aware of it and our management were aware of it and taking care of it, but our pharmacists actually weren't aware of it at the time. And so when I brought this up with our staff, I just started mentioning to different, some of the techs, is there anything that you've noticed that seems like hasn't been getting fixed? And the sash, the little chip on the sash, and then there was also a spring mechanism that was making the sash difficult to open and close, and we got both of those things fixed. So make sure you're reaching out to your techs and your pharmacists and asking them if they've noticed anything that they've brought up and hasn't been fixed, or if they're just wondering or waiting for something to be fixed, because sometimes they either think it was communicated and it wasn't, or it was communicated and you just forgot and need a reminder. So the next question I asked Chris is, will we see a new Board of Pharmacy regulation on hazardous drugs? And right now the answer is no. So there will not be a chapter or a Board of Pharmacy reg based on Chapter 800 USP. When will we see the new regulations become official? Probably either this summer or the fall. What are some common concerns you see with USP compliance in the new regulations in pharmacies throughout New Mexico? The new regulations have not been added yet, and I don't think enough time has passed yet to see how the revised USP 797 is affecting our compounding facilities. What do you think is the most significant change you added to the new Board of Pharmacy regulations as a result of the new USP chapters? In terms of sheer number of changes, I would say probably the definitions being updated from the old USP 797 to the new one was most significant. But in terms of affecting practice, maybe the language we added to personnel training and testing, as well as record-keeping requirements. But for the most part, the language comes from the revised USP 797. So basically, what Chris is saying is if you're ready for the new 797, you should be ready for the Board of Pharmacy inspection. So I just wanted to touch on this important point again, that your pharmacist in charge must be fingertip tested if you're following 797 in your pharmacy. And that's because your pharmacist in charge is your designated person, regardless of whether they're sharing that role or they've delegated that role to another person. So this will be regulation language in the Board of Pharmacy. The PIC must be fingertip tested because they're the person, the designated person, the person who's in charge of overseeing the compounding. So think about it in the pharmacy. Who's your PIC? Is it the executive director, somebody who doesn't even look at IVs or may not even go near the IV room for weeks? Do they do much compounding or even checking at compounds? There's always an opportunity to change the PIC to somebody who's maybe more hands-on or is doing the day-to-day stuff in the pharmacy. The good news is the designated person only has to be fingertipped once a year, not twice a year. So now getting into USP 800. One thing to remember is the focus of USP 800 is on worker safety, whereas the focus of USP 797 and 795 is more on patient safety. You've probably already prepared for USP 800, so we're definitely going to focus on what we did here at UNMH And please feel free to reach out to me with any questions or any comments, or if you notice we do something that you think you do better, let us know, because we'd definitely like to be on the up and up with everybody. So an important point about USP 800 is don't do it alone. The USP 800 guidelines specifically state that the compounding facility must designate one or more individuals. And it doesn't say whether it has to be a tech or a pharmacist or a nurse or safety or EBS or anybody else you want to invite. So even if you have a specific hazardous drug oversight committee team, make sure that you involve many other people to get insight and buy-in from other members of the staff. So what I did to educate our staff is I made a YouTube video that described how we put everything together. And so I thought I'd share it with you. It's a quick little 2-minute video. Why the new concerns with hazardous drugs? Here's a 3-minute embellished and historically inaccurate animated explanation. So it's 2004, and the National Institute for Occupational Safety and Health was like, we've been making hazardous drug recommendations for like 20 years. Are we doing enough to protect healthcare workers? Let's take it a step further. How about we list out all of the drugs that are hazardous and make some recommendations to keep healthcare workers safe? Yup, there we go. Healthcare workers are safe forever thanks to our recommendation. So about 8 years pass, and NIOSH is looking at the safety data, and they are very happy. So they call up USP, and they come in hot. They're like, USP, we need some help. We've been making recommendations for like 30 years, and it seems like no one but UNMH is following them. Nurses and babies are getting sick, like bad. We need some regs. We need some regulations with some teeth, but not like that. Yeah, like that. And we want TJC, the boards of pharmacy, and OSHA all to be down. It should be law that all cytotoxic drugs like methotrexate, cyclophosphamide, and cytarabine should be handled carefully, made in a hazard with a closed system transfer device, and then administered carefully. And USP was like, yeah, you got a point there. Cytotoxic drugs are dangerous. So NIOSH was on a roll, and they're like, yeah, the same goes for fosphenytoin, Depo-Provera, and oxytocin, and everything else that's hazardous. And USP was like, no. But thanks for the list. So USP got together and they're like, let's put this in black and white. Let's write some regs. Sure thing. We'll cover all things hazardous from receipt to administration. We'll include sterile and non-sterile compounding. What about that NIOSH list? Let's do this. Compounded cytotoxic chemotherapy follow all of the USP 800 rules. Everything else needs to be part of an assessment of risk. And so USP 800 was pretty much done. Why they titled it USP 800? I don't know. So USP sent out a draft, and a team of nurses, pharmacists, and safety got together and formed the Hazardous Drug Oversight Committee. But they were like, dude, we pretty much do all of this stuff. Cool, let's just write our SOPs and we're out of here. So what about that assessment of risk? We did need to go drug by drug through the NIOSH table, so we called up some other facilities and looked at what they were doing. We agreed on a few algorithms, and we set up a big Excel table based on those algorithms. But in the end, we thought, 3 pages of algorithms? That doesn't look so easy. Okay, how about we break it down into 2 categories, A for hazardous drugs and C for chemo. Wait, what about category B? What happened to that? Well, there are A batteries and C batteries, and nobody asked about B batteries. Batteries are a good analogy, but maybe we could make it even simpler. Let's call it for C for chemo and H for hazardous. Oh yeah, that's a lot better. From there, we finalized our documents, made some education, took our documents around to a bunch of different UNMH committees, and then shared and discussed with other facilities throughout the city, state, and even the nation. Now we'd like your opinion. Let us know if you can find any ways to improve our handling of hazardous drugs any further. Thanks, that's it. One thing we do that involves many other floors is our hazardous drug surface sampling. So twice a year, we meet with our nurses and our pharmacists to decide where in the hospital we're going to do surface sampling testing for hazardous drugs and what drugs we're going to test from. I use shared documents to make this determination. It helps organize things and helps get insight from the nurses. And it's always good to let the nurses know when they're coming and let them decide what's important. For example, one time one of the nurses suggested checking around the toilet for hazardous drugs, and we found some. I think it was some etoposide or something like that. So the nurses have unique perspectives and interesting ideas on where to check and what to look for. I found for chemo spells that a video is worth 1,000 words. We got together with some of the nurses and put together a how-to deal with chemo spells, and it's actually on Vimeo, and it's free for anybody who wants to see it if you can find it. Let me know and I can share the link with you. But I have this link queued up on my phone just in case I'm ever on the spot and asked to help clean up a chemo spill, so I know what to do, because sometimes chemo spills are few and far between, and you want to just make sure that you're doing it right. So it's always good to have this on hand. And then, as you know, typically they call pharmacy for help with chemo spills, and it's actually part of our policy to call pharmacy to help with guidance on chemo spills. If you're one of the facilities that is not going to treat all hazardous drugs the same, you need an assessment of risk. And I have a quote from USP 800 down below. It says, "For the purposes of this chapter, the term antineoplastic only refers to antineoplastic drugs included in Table 1 of the most current NIOSH list." That means for Tables 2 and 3, it's up to you to make an assessment of risk and figure out what to do with those drugs. The way we did it is every year at our May Hazardous Drug Oversight Committee meeting, we go through our current hazardous drug list and we review an algorithm we created. So we sat down and for about an hour and agreed on what makes a cytotoxic chemotherapy hazardous and less hazardous, and how do we handle all these drugs in accordance with USP 800. After we agreed on that algorithm, then it's pretty easy because you can just code the algorithm into an Excel spreadsheet and put the characteristics of the drugs that you're evaluating in the algorithm, and the Excel spreadsheet will decide what to do with each of the drug, of course, based on your algorithm. Typically, there aren't too many changes to our algorithms every year, but we are anticipating the next NIOSH list will have big changes, but we'll get there when we get there. There are some advantages. One is consistency between individuals. I know when I'm grading something myself, I tend to be easier at first and then get harder at the end. And then if you were to divide and conquer your NIOSH list, then there could be differences between individuals as well, and so you could get some inconsistencies. The disadvantage is you have to make sure if you're creating an algorithm, especially something that's coded into a machine, you need to make sure you still comb through that and look at all the nuances of the different drugs and formulations and have all that accounted for. But I found it's much easier to have an entire sheet that's all filled out and you're just double checking the boxes rather than fill in the little boxes yourself. So let me show you our assessment of risk. Welcome to our assessment of risk. As discussed in my YouTube video, we have two handling categories. So that's this colored column here. We have category C, which usually is cytotoxic chemotherapy, and category H, which is hazardous, including cytotoxic chemotherapy in its final form, for instance, cyclophosphamide tabs. In each one of these cells are logic based on our algorithm. So you can see here there's some simple if-then statements in these cells that just describe how to handle each drug based on the features that we agreed upon in our algorithm. The beauty of building the features into an algorithm in the cells is that after you've determined what features of a drug you're going to assign a category H or C, and then how you're going to handle it, all you have to do is drag the cells down with this little right corner in Excel, and it will fill in all the details for you. So it lowers your risk of having typos, and it makes it all nice and neat and consistent. For disposal, there are some caveats, and there are some caveats here on my OK to Crush list too. Remember that arsenic has to go in its own arsenic bucket, but there aren't very many drugs that have really unique handling scenarios. Make sure that with your assessment of risk, you include each drug, but also each drug's formulation. So you can see here, let's find a good example, abacavir comes in a solution and a tablet. And so both the solution and tablet should be listed because sometimes you handle things differently depending on their formulation. In addition, on my assessment of risk, I have a header with a whole bunch of caveats and information. And then on the very bottom, there's also some footnotes with additional information. Just let me scroll back up here. So here's some additional information at the bottom of my assessment of risk as well. Our assessment of risk is supported by our safe handling of hazardous drugs procedure. I don't go into the procedure in this presentation because it's really just how we apply USP 800 to our facility. there are references to the assessment of risk in our procedure, and it describes in detail how to use the assessment of risk. This assessment of risk document is then saved as a PDF and loaded onto our pharmacy website, so it's available to our staff while they're working on the floors. I wanted to emphasize the importance of looking out for new drugs when you're doing your assessment of risk. In this chart, we have new drug approvals from 2018 to March 2024. And you can see approvals for oncology and hematology drugs outnumber all approvals for diabetes, heart disease, blood pressure, cholesterol, migraine, depression, seizures, and all infectious diseases combined, and it's not even close. So these oncology drugs come out fast. And even if you are at a hospital and you don't do any outpatient treatment, chances are sometimes patients are going to bring in their own meds, and you need to know how to handle those as well. So evaluating new drugs prospectively before they're even out on your formulary is a good way to go about things, because you need to know how to handle patients' own meds. It's important to review new drugs that come on your formulary and cross-reference them against the NIOSH website, and I'll show you, I have a slide on that in just a second. And just remember, these oncology drugs are coming out really fast, and it's important to keep ahead of them. In our hazardous drug oversight team, we make drug review a standing item on our agendas. Every quarter, I review the FDA website for any new drugs, and then I make a list of them, and I plug them into the assessment of risk algorithm if necessary. So in this example here, buprenorphine would not be considered a hazardous drug, so we wouldn't really consider that for assessment of risk, but ruxolitinib definitely would. And then CAR-T, those are new, exciting drugs. We actually just did our second CAR-T for the state of New Mexico just last week. So pretty exciting stuff, but that's actually not a hazardous drug. So, and then there's also these oncology drugs, talquetamab and epcoritamab, that are monoclonal antibodies. They treat cancer, but they are not hazardous drugs for our purposes. So it's never bad to review what's new, especially as leaders. Sometimes you forget some of the clinical stuff, and so it also helps you just keep abreast of what's what they're talking about in the market. As I mentioned, NIOSH has hazardous drug updates on their website. There hasn't been any updates since May 9, 2023, so over a year, but that's because there haven't been any new injectable hazardous drugs brought to the market. Of course, you feel free to review all the drugs the FDA's approved for hazardous indication and treat them however you wish. But I kind of use this website as a must, or a should, or sorry, a shall, in treating drugs as hazardous or not in our hazardous hoods in our IV rooms. One thing to note is the NIOSH website is good at identifying and working with IV hazardous drugs, but they're not very complete with their oral oncolytics. And as we know, nowadays, oral oncolytics come out pretty much at the same speed as IV oncolytics. This list isn't all bad news, though, because they're reviewing pertuzumab and liraglutide for removal from the list, and that would be a big win for us. We've always kind of wondered why pertuzumab was on the hazardous drug list, and so one less drug to have to put through our BSCs. And liraglutide, I'd imagine, would be important for outpatient pharmacies and retail pharmacies. One creative way we addressed one of the issues in USP 800 was to buy these signs from Healthcare Logistics. They're really cheap, and if you need any information on buying them or the order numbers or anything like that, let me know. We have these stuck to the doors throughout the facility where there are hazardous drugs. And this is addressing the part in the USP 800 chapter that says, HDs must be handled under conditions that promote patient safety, worker safety, and environmental protection. Signs designating the hazard must be prominently displayed before entrance to the HD handling areas. So again, let me know if you want me to, or any tips on how to purchase these little chunky signs, but they look really professional and they're really nice, and so we just have these stuck around our hospital where there are hazardous drugs. So for hoods, there's a lot of misinformation out there. It's really difficult to find a comprehensive resource for hoods on a side-by-side comparison. And there's a lot of misunderstanding. You know, if you go to a certain website, they might describe different types of hoods in different ways. But here's how I try to keep it straight. I made a big, huge shared chart, and let me just show you around really quick. And again, let me know if you want this chart. It's all part of the same Excel. So welcome to my Hoods tab of my document. And you can see in the top here, I have a few different headings. I have the type of hood, the subtype within the hood. Remember, Class 2 has a few different subtypes. Whether or not hazardous compounding can take place within the hood, whether or not sterile compounding can take place within the hood, what type of protection the hood offers, product protection, environment protection, and personnel protection, HEPA filtered air into the hood, the exhaust, and a few other things. I've found this table is helpful not only for me to keep the hood straight, but also to communicate with facilities and with nursing and safety and other parts of the hospital, because again, sometimes they speak a different regulatory language, and sometimes this ducting information makes more sense to them than it even does to me. It's difficult to find sources on different types of hoods because it's kind of an esoteric practice that we do. And so you have to be careful on your sources and where you're getting your information, because it feels like sometimes there's some different definitions out there. Down here, I have different information about the rooms, such as SECs and CSECs. I have the ISO class required, air pressure differential, venting, air changes per hour, compounding categories. Remember, in USP 797, there's 1s and 2s, and whether or not hazardous drugs can be compounded in the room. This chart's a little more straightforward because there's not that many different types of rooms. But again, if you are interested in these documents, let me know and I can email them. One other note for hoods is that USP 800 actually has a great summary in their appendix of the different types of hoods they mention. And again, when we're talking about hazardous drug compounding, we're really focused on BSCs, because those are the primary instrument that most pharmacies use to compound hazardous drugs. There's class 1 and class 2, and then within class 2, there's types A1, A2, B1, and B2. And a lot of it has to do with where the exhaust is going and how much is filtering back into the room versus going totally outside of the building. One caveat with these hoods is, you know, the type 2 total exhaust, you need quite HVAC system to pull to do a total exhaust. They're great, but make sure that your building can handle it before you purchase those. That can be a challenge. So all of our staff have to be educated on hazardous drugs every year. At UNMH, as part of our Learning Central competencies, we have an annual training in hazardous drug risk acknowledgement that's part of our annual training learning modules for employees. So within this, it states, you know, essentially that I, as a worker, realize that I'm handling hazardous drugs and I need to be extra safe because this could affect my ability to give birth, or if I have a baby, it could affect my baby if I expose myself to too many hazardous drugs. So it has that kind of language in there, but it also has information on how to be safe. And we made 4 separate customized education pieces, one for pharmacy, one for oncology nurses, one for staff who do not handle chemo, and then one for everybody else. These meetings are absolutely fun because I virtually meet with nursing every year to update these modules, and we go through and update them all and have discussions about what needs to change. And it's just a great multidisciplinary approach to making hazardous drugs safe. So I thought I'd wrap up by just discussing the EPA. I think we don't discuss EPA enough, and the EPA is definitely another organization that will come to your pharmacy and look over how you're handling hazardous drugs. I usually think of climate change when I think of EPA, but they actually have an active part in monitoring our healthcare facilities. We've had the EPA come into our facility, and they actually will dig through your garbage to look for anything thrown away inappropriately. So, and there's a big fine, and it definitely goes through the upper levels of management if they find anything. There are national and local laws to worry about. You've probably heard of RCRA, and you've also probably had a surprise visit from the EPA at your pharmacy, and it's just never fun, and you always want to be prepared. So there's EPA federal regulations. When we talk about RCRA, there's actually, this is actually something you can look right up. The RCRA Resource Conservation and Recovery Act, their Title 40 of the Code of Federal Regulations, parts 239 through 282. There's 239 through 259, which are non-hazardous, and 260 through 282 are hazardous waste. Your safety and compliance team will be very familiar with this regulation. It is pretty confusing with the large generator and small generator stuff. Consider perusing Subpart P. It will definitely be in New Mexico's future. There's a lot of states that have already adopted it, and I think it's a big improvement to the current laws. So what to know about current EPA regulations in New Mexico? Right now, hazardous pharmaceutical waste is regulated through 40 CFR Part 262, but hopefully in the future it will be 266 Part P. Many healthcare provider or facilities are large quantity generators because of acute waste portion of the generator status. And acute waste is specifically, well, in our case, arsenic and warfarin. In the future, OTC nicotine replacement products will no longer be needed to be handled as hazardous, nor will warfarin wrappers. Remember that patients don't need to follow RCRA guidelines, it's just facilities, so patients can go throw their warfarin wrappers away in the garbage. Hazardous waste, not hazardous drugs. So the NIOSH list was last updated in 2016, whereas the EPA list was last updated in 1976. And as you probably know, the EPA has two lists. There's P-listed and U-listed drugs. It's super confusing. And the NIOSH list and EPA list only overlap a little bit. And again, the EPA, although the NIOSH list has their updates on their website, the EPA list has no updates. And so the EPA list is still where it was 40 years ago. Many NIOSH hazardous drugs do not meet EPA's definition of hazardous waste. Okay, so the EPA has a P and U list. P-listed drugs are typically more toxic than U-listed drugs. You can see arsenic on there. Nitroglycerin and epinephrine are on the list, but pharmaceuticals are not P-listed. And the rationale is nobody has ever seen a bag of nitroglycerin explode, although nitroglycerin is obviously explosive, not in the concentrations we use here. And epinephrine salts that we use to treat patients are not hazardous like the base. Many chemotherapy agents are U-listed, but not all. And again, that's because RCRA was written in 1976 and not updated since. There are states like California that have a RCRA and non-RCRA hazardous waste list. So EPA's Subpart P amendment, this chart here is pretty interesting. It's updated by the EPA themselves because I think they really want more and more states and facilities to adopt the EPA's Subpart P amendment. You can see the blue states are the ones that have adopted it. Most states, but not all. And New Mexico is not has not adopted yet. In EPA's effort to separate healthcare facilities from hazardous waste generators. And so this is really, drugs should not be treated like hazardous waste generators of big chemical companies. And so this is EPA's effort to kind of distinguish between a healthcare facility and a big chemical company. I call the EPA every year to check in, and there's currently no plans to implement it. And I did get a hold of the EPA, and I'll go through my discussion with them. Overall, there's some good changes in there, so if you know any lawmakers, make sure to bring it up with them and give them a nudge. Say, hey, what's going on with Subpart P? So here are some of the reasons you should bug your lawmaker about getting Subpart P adopted in New Mexico. For one, a healthcare facility will not become a large quantity generator with all the associated requirements when it generates more than 1 kilogram of acute waste. So hazardous pharmaceutical waste will not contribute to the waste status of the facility. And that's good for the facility in general. A healthcare facility will not have to comply with the satellite accumulation area regulations, which are a poor fit for healthcare facilities. They will not need to specify hazardous waste codes on manifest, but you still have to write hazardous pharmaceutical waste on your black buckets. A healthcare facility will be able to accumulate hazardous waste without RCRA permit for 365 days, which is an increase of 275 days. They will have basic training requirements, and they can commingle hazardous and non-hazardous waste because there's no difference in waste handling between small quantity generators and large quantity generators. Now everything can go in one bucket. Of course, except for combustibles like arsenic, which is a heavy metal in aerosols, it can't be incinerated, according to the New Mexico Department of Transportation regulations. So yet another mix in the alphabet soup to worry about. There's also benefits to empty container statuses and no more requirements of triple rinsing, which is just a confusing topic on its own part. So I reached out to the EPA to ask what's going on with Subpart P, because a lot of states have adopted it, and it seems like it's a great thing for New Mexico to adopt for our healthcare facilities. And what's the deal? Why haven't we adopted it yet? And so here's my email exchange with them. So good afternoon, Nick Crozier. This is from Alexis Lewis, and I assist with web forms sent to the EPA. New Mexico has not sought authorization for Subpart P. The state has adopted Subpart P federal regulations prospectively. However, the EPA has not approved the method of their adoption and has not approved the state's regulations to administer Part P. If you have any other questions, please let me know. And for anybody who's a lawyer or has a lot of law experience, adopting prospectively, it might make sense to you, but I wasn't sure what that meant. So I asked, does New Mexico operate by Subpart P right now? And they replied that the EPA has authority and implements regulations under the Solid Waste Amendment Act of 1984. The state is not authorized for those portions of the regulation until the state seeks authorization from the EPA and approved to operate portions under Subpart P. What does prospectively mean? Prospective incorporation by reference means the New Mexico Hazardous Waste Regulations, effective 12/1/2018, incorporates by reference each part of the federal hazardous waste regulations as it is modified or amended, rather than providing a specific date. This means that the state's incorporation by reference includes any EPA regulations that may occur in the future. In general, states are allowed to prospectively incorporate federal regulations by reference. However, states must provide to the EPA their statutory authorities to adopt the federal regulations and to enforce regulations adopted in such a manner. Now, again, if you're a lawyer out there, I would love to hear really what that means. It sounds like a bunch of legal jargon. To me, I don't really understand why we can't adopt this by reference, but I guess the explanation's here. And I don't know if this is just a simple matter of somebody from New Mexico stating their statutory authorities, or I don't know what kind of things need to be passed in our Congress or our state to get this going. But it looks like some just kind of minor stuff that's really holding us up. But I don't know. I don't understand that. But that's the explanation. Is there a timeline for New Mexico? Yes. See the question below for your answer. Also, further information, contact the state to address the timeline. I call them, like I said, every year, and I don't get really a clear timeline. And I asked, wasn't Subpart P supposed to be adopted a couple years ago by all states? The answer is yes. The state modification for the state to adopt and apply for authorization deadline was July 1st, 2020, or July 1st, 2021 if a state statutory change is necessary. The rule promulgation date was February 22, 2019. So interesting that we're way past the deadline, yet there's still some back and forth to figure out. But again, it sure would be great if they sort this out and we can move forward with the sub. I'd like to close by going through a few other chapters in USP. And if you have access to the UNM libraries, you have access to all the USP chapters. There's hundreds of them. It's great. Let me know if you need the link, because accessing this part of the library is hard to get to, but it requires a login, but it's free to make the login. So it looks like you have to pay for it, but you actually don't if you have a UNM account. So let me just show you some of my favorite chapters. Okay, here are some of my favorite USP chapters beyond the 797, 800, and 795. 659, if you don't have this chapter, let me know. This is the most wonderful chapter for excursion recommendations. It has saved me so many times. We'll go into it in a couple slides. 790, visible particulates in injections. That's kind of obvious, but it's nice to have in writing that it's expected to be 100% checked. And it's great pharmacist reference and a great teaching tool. 1151, pharmaceutical dosage forms. That gives a detailed breakdown and definition of each dosage form. 1029, good documentation guidelines. This is great guidance for giving details about putting together your SOPs. And so take a look at that while you're writing your SOPs. 1072, disinfectants and antiseptics. There's a great discussion on the different types of cleaning agents. Sometimes those are hard to distinguish because there's a lot out there, and it breaks them down for you. And then 2750, manufacturing practices for dietary supplements. I know dietary supplements are always something I'm a little worried about because there's not a lot of good regulation, but USP has actually made an effort to put forth recommendations there. Chapters 2000 in the 2000s are dedicated to dietary supplements. So just to highlight my favorite chapter, 659, because it has saved me so many times, there's just great information here about excursions. And you all have probably been called into your pharmacy at 2 in the morning about a fridge going out or some room getting too hot. And this guidance just lets you off the hook sometimes a little bit. You can see here controlled cold temperature is 36 to 46 degrees, but it allows for excursions between 36 and 59 that may happen every once in a while. They do say that this should only happen once, but hopefully, your pharmacy is stable enough to where this isn't happening often, especially with your refrigerated items. But I know I have definitely used this chapter when having to come in at 3 in the morning and rescue a bunch of drugs from a fridge that was failing. Controlled room temperature, no surprises there, 68 to 77. But again, it gives you an excursion window of 59 to 86, which is pretty big, and even transient excursions up to 104 degrees. And it doesn't have that one-time limit. So just another thing to note, that if your room gets a little hot, you probably don't need to throw away all your drugs, because USP actually gives you specific guidance that says it's okay sometimes. There's also this line here that says, an article for controlled room storage may be stored at a cool place or refrigerated unless otherwise specified. So what that means is, unless the monograph specifically says you cannot store this drug at less than 68 degrees, you're okay. And we actually have a room, or we had a room like that in our pharmacy, where we had a consultant come through and ask, hey, you can't, or we had a discussion, and they said, this room is running cold, what's your plan? And according to 659, it's perfectly fine to keep drugs a little bit cooler, as long as there's no manufacturer that says you can't do it. So this really got us off the hook in that case. So yes, there is a chapter on inspection, visual inspection of injections. It's pretty straightforward, but it is expected that 100% of products are visually inspected for particulates in USP 790 and 1790. And there was actually a pretty interesting conversation on one of the, I think, ASHP listservs about using remote checking. So for instance, we use Dosage to make sure things are checked, but is that good enough? Some institutions say no, that in addition to your Dosage, you must also have a pharmacist there to actually look at the bag and make sure there's no particulates in the final product. So just kind of interesting discussion on remote checking, and if remote checking is good enough to suffice for the 100% visual inspection of injections. That's a debate for you to take forward in your own facilities. And there is a USP chapter, I was going to say 800, 1044 on cryopreservation of cells. So as New Mexico, we're moving forward with bone marrow transplant procedures. We're doing allo now in addition to auto, and we're looking at storing our own cells on site rather than shipping them off to Phoenix. This chapter has a lot of good tips on the rationale for certain products, such as DMSO and proper freezing and thawing of cells. So really sets you up with some good advice on how to do this. All right, that's my presentation. Thank you so much for having me as a presenter. And I want to thank NMSHP for having me as a presenter as well. And anybody who's thought about doing a presentation, just know this is a great way to learn more about a subject. In my case, I spent a lot of time going through our procedures and through different things going on locally and nationally, and I really feel a lot more educated on these topics myself. So this is really a win-win if you're interested in doing these presentations. So make sure and go for it. I'll take any questions you have now.